My name is Philip Keiser. I'm a professor of medicine at the University of Texas Medical Branch, and I'm speaking on behalf of the South Central AIDS Education Training Center. And I've been involved in HIV care since 1985. I saw my first HIV patient when I was a third-year medical student, near the end of my third year. And I was an intern in 1986 and had a patient who was a young gay man and came to see me, and I treated him with AZT. And you know, at the time it seemed like we were really on the cutting edge, and now it seems like so much time has passed. And one of the keys, I think, that we see in trying to contain this epidemic is to prevent HIV. Okay? And that's what I'm going to be talking to you about. I'm talking to you specifically about PrEP, or pre-exposure prophylaxis. Now, PrEP is the idea that you can prevent HIV by taking a pill. All right? And why is that revolutionary? Why is that different? Well, if you take a typical epidemiologic approach toward preventing a disease, is you define the risk group. And once you define the risk group, you define the risk factors among that group. And once you define the risk factors in that group, you define what the prevention is, and then you get those individuals at risk to do it. So in HIV, what is that? Well, HIV, who's the risk group? Primarily people who have sex. Well, we don't think of it that way in America. We think, you know, it's gay men, it's drug users, it's prostitutes, it's other things. But it's basically, it's people who have sex. And then what's the intervention that we use? Well, primarily, the main intervention that people have used over the years is a condom, right? So here we have this nice picture of a condom, and it looks like a woman's hand to me. And what you can see is there in the background is this guy sitting there going, now, you want me to do what? You know, and this is the problem with condoms. Condoms are not universally accepted for a lot of reasons, okay? I mean, sometimes people just don't like the way they feel. Sometimes people are uncomfortable with condoms. But, you know, a man may be wearing a condom, and a woman may find that very uncomfortable, and it reduces the pleasure. It also, there are other messages that go in with condoms. I mean, look at this particular relationship here. We don't know much about what's going on. But what does that say about him when she says, I want you to wear this, all right? Is she telling me that she has a disease and that I'm at risk for getting sick? Or is she telling me that she thinks I'm at risk for giving her something and making her sick, right? And so there's a lot of dynamics that go back and forth. And within those dynamics, particularly when we look at the worldwide HIV epidemic, we have to consider the fact that most people, and when I say most, I mean most by huge margins, are heterosexuals, right? We're talking about relationships between men and women, right? And so there's a power issue there, and particularly in countries where there may be different expectations of women than men. And so a woman to say to a man, you know, here, I want you to wear a condom, that can be a very, very difficult thing. Now, I've even had some of my patients tell me that they can't use condoms. They can't use condoms because my boyfriend doesn't like it. And so I tell them, look, I'm a guy, and let me tell you, if a guy's given a choice between having sex with a condom or no sex, he'll choose sex with a condom every time. Maybe not, though, right? Maybe not. Maybe he'll choose to beat the crap out of her, right? These are the things that kind of happen. So condoms create a sort of a power imbalance between the person who has to wear the condom and the person who doesn't have to wear the condom. And so that's one of the problems with using condoms as our sole means of trying to prevent HIV infection. Now, there's some other ways that people have tried to do it. One of them is the female condom. How many of you have ever seen a female condom? Yeah, right. How many women would want to use a female condom? Nobody's raising their hand, okay, right? Because, you know, it's basically, it's the size of this condom, only, you know, 5 times larger, and it basically, the woman has to basically insert it up around the cervix, it has to fit in the right spot, and then it hangs out. And then, you know, you're all ready, and the guy comes, and he goes, what's that? Why, it's a condom. It doesn't look like any condom I've used. Well, it's not. So female condoms basically have been a flop. They have not been widely accepted. They haven't been widely distributed. When I was at Parkland, we actually had female condoms to give out, and the women wouldn't take them. They wouldn't use them, and so they really haven't worked very well. And so another thing that folks have tried to do are vaginal gels. And so basically, okay, so here you are, you're going to be the receptive partner, and this could actually work for gay men as well who are receptive partners. But basically, you take this, you stick it in your vagina, and that will help prevent HIV. But they've had mixed results. And they've had mixed results for several reasons. First of all the preparations necessarily haven't been that good in terms of preventing HIV. Some of them actually were irritating to the vagina, causing breaks in the vagina, and women who used them had higher rates of HIV than women who didn't use them. And then there comes the whole preparation issue. You know, okay, it's sort of like, okay, I'm getting in the mood, I'm getting in the moment. Oh, okay, wait a minute, let's stop, I got to put the gel in, you know. And so, again, not very widely accepted, not very acceptable. So then someone came along with this idea, this little blue pill. This is called Truvada. And Truvada has 2 HIV medications that we use in it. One is called tenofovir, and the other is called emtricitabine. And these 2 medicines are part of a large portion of HIV medicines that are used around the world. It's used to treat HIV, along with one of the active agents that Dr. Fox was telling us about earlier. But someone came along with the idea and said, well, what happens if we give this to people as a medication to take before they have sex? That way, they have control over it, right? I don't have to convince my partner to wear it, or I don't have to explain to my partner why I'm wearing it. It's totally under my own control. It's totally confidential. We should use this. And so some people did some studies in animals, and they did some studies in monkeys, and it seemed to work. And then the idea was, well, let's go ahead. Let's go give people this drug, and it will prevent everyone from having HIV. And then there was a lot of pushback. It's like, whoa, 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 you can't do that. Well, why can't we do that? You mean you're going to tell people to take a pill every single day to keep from getting HIV? And people went, well, yeah. Oh, they'll never do that. They'll get resistance. The HIV will get resistance. And these people, then they'll have resistant virus. And this drug that we use as one of our mainstays of therapy won't be any good anymore. And you're going to ruin it for the people who have HIV, and it'll be all your fault. Or what about the toxicities of this drug? This drug causes renal failure. This drug makes people's bones get thin. You're going to give to these people and you're going to make them sick. So what's the answer to these questions? Well, the answer to these questions is that it's been tried in tens of thousands of people, and it pretty much works, right? It pretty much works. You give it to HIV-infected women, and if they take the medication, they don't get HIV. You give it to gay men, and if they take the medication, they don't get HIV. But there is also sort of, as you look at the study, there's a little bit of a mixed bag. So for example, HIV-infected women in Africa, a lot of them still got HIV even though they were taking the medication. Not as many as women who weren't taking the medication. And so what was happening was that some of the women were taking it all the time, some of the women were taking it some of the time, some of the women were taking it none of the time. And the women that took it all the time didn't get HIV. And the women were some of the time, it really depended how much of the drug they had in their bloodstream. And actually, retrospectively went back and worked it out and checked levels of blood in people's bloodstream. And it turns out that if you reach a certain threshold in terms of the amount you have in your blood, it works. So that got people thinking about what are ways we can improve it. It works, but it doesn't work consistently, and it doesn't work as well as we would hope. What are some ways we can do it? Well, there was a study called the IPER-GAY study, and this is oral on-demand PrEP, primarily targeted at gay young men in Europe, primarily in Great Britain. Okay? And so these are young guys, 18, 19, 24, 25 years old. They're out partying. They're having a good time. Okay? All right? As kids will that age do. And so they were offered on-demand PrEP. And what does that mean? That means you go to the clinic and you say, hey, I have a hot date tomorrow night. I want some PrEP. Now that just sounds crazy to me. When I hear that, that just sounds total. What do you mean? You're going to give this guy a pill because he has a date? You know, if my son came to me and said that, I would just slap him silly. It just doesn't make any sense, right? But guess what? This is what happened. So people would come in, they'd get on-demand PrEP, they'd get their pill like 2 days ahead of time, they'd keep it for another 3 or 4 days, and boom, they'd be done. They wouldn't keep taking it. And look at what happens to those individuals. This is the rate of people that have HIV when they're on placebo, okay? And you can see about 14% of them got HIV. And this is the rate of the cases of people not on placebo. In fact, each one of these little boxes counts as one case. So basically, only 2 people got HIV, and quite frankly, in retrospect, they got their drug and they didn't take it. It works. It keeps people from getting HIV, and it seems to work the best when people can use it and plan around their sexual activity. And you think about that compared to the African study, that makes a lot of sense, right? So here, these guys know I'm going out, and or I've got a date, or I'm going to, you know, I'm going to go have sex. In the African setting, what you have is you have women who are negative, who are married to positive partners, and they have to take it every single day, okay? And then it also gets back into both that power dynamic and what does it say about me and my partner. And so not surprisingly, a lot of the women didn't take the PrEP the way that we would have wanted them to. Now the good news is you can do this intermittently. But if you want to make a virus resistant, this is what you do. You give it to somebody, a drug to somebody for a short time, and then you stop it. And then you give it to them again, and then you stop it. And then you give it to them again, and then you stop it. So what would you expect in a study like this? You expect a lot of resistance, right? Guess what? Didn't happen. See, that's the beauty of science. We love to sit there and we love to predict what's going to happen, and we pontificate and we say, oh, you can't do this because of blah, 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 blah. And then you do the experiment and it doesn't happen the way you expect it to be, and because the facts are different. And then we turn around and we very piously explain why this is the right result. And of course, we should have known this all along. And that's what academics do, and that's how we keep our jobs. But resistance didn't happen. Not only that, toxicity. Almost no toxicity among these group of young men. Not only just in this study, but in studies across the board. And so now we have a situation where you can prevent HIV by giving people a single pill planned around their time of sexual activity, where they take it for several days, stop it when they don't need it, and then those individuals will not be at risk for getting HIV. They don't get resistance, at least not that we can tell, and there's not issues of toxicity, at least within the periods of time we've been able to watch people for short periods of time. So that's all really good news. But we're giving all these guys, you're giving these young gay men, come on, and we know young guys, you know, they're going to go out there and they're going to have sex, and they're going to have a lot of sex, and you're giving them a pill, and they're not going to wear a condom, and they're going to get syphilis, and they're going to get gonorrhea, and they're going to get herpes, and you know, it's going to be a big bang. You're just going to make everything worse, right? Guess what happens? Decrease risk behavior over time. These are 2 different studies. And this shows the numbers of subjects that reported unprotected receptive anal sex, the most highest risk form of sexual activity for acquiring HIV. And then in this next one, it's subjects reporting no, basically any unprotected sex. Look what happens. Boom, it drops down and it stays down. This one drops down and it continues to go down. And what is happening is that people that are interested in enrolling in this program, they're getting the messages, right? They're saying, okay, I can take this pill and I won't get HIV, but you know, they also told me that I need to be careful about other sexually transmitted diseases. And they also told me that this pill isn't 100%, so if I wear a condom, that can help protect me even more. And people are acting more responsibly over time. They're having decreased risk. Here's another one, okay? Condom use, increase. Almost immediately, condom use is increased. And there's several small studies that have looked at just the number of rates of sexually transmitted diseases, and they don't see an uptick in sexually transmitted diseases in patients that are getting PrEP, okay? So it's working, and it's working very well. And we have some challenges with it, though. And some of the challenges are, how do we get the drug for our patients? right? It's an expensive drug. Well, most insurance companies pay for it, and the manufacturer of this drug, Gilead Pharmaceuticals, if you don't have sufficient funds to pay for this drug, they will give you the drug. Okay, got to fill out some paperwork, but they'll go ahead and give you the drug. All right, well, but don't they have to go see a doctor? Yeah. Well, who's going to pay for that? Well, that's a problem. Don't they need lab tests? Yeah. Well, who's going to pay for that? Well, I'm very happy to tell you that here in Galveston County, we're actually addressing those issues. So, in collaboration with UTMB, with the Access Coastal Care of Coastal Texas, and the Galveston County Health District, we've just set up a PrEP clinic. All right, and so the PrEP clinic is actually being managed at the Galveston County Health District. And Access Care Coastal Texas is actually providing the funding through private funds for those individuals who don't have the money to pay for their doctor visits and don't qualify for free care. And so we're moving forward. And you're seeing things like this all over the country. City of Houston has started a big PrEP initiative where they're actually encouraging people and doctors to provide PrEP and giving them help and how to access various things. And you're seeing it happening all over the country, that individuals are now beginning to get access to PrEP. But this is only half the story. We started off talking about how do we reduce HIV infection and how do we get toward zero in terms of the numbers of new infections. And there is an initiative that's currently going on in San Francisco. And what City of San Francisco has done, is they've basically said, we're offering on-demand PrEP. You want PrEP, you can get it. And if you are newly diagnosed with HIV, we want you in care and on drug in 72 hours. Right. Now, they're not getting everybody on care and in drug in 72 hours, but they're getting a lot of people on care and in drug in 72 hours. And look at what's happening to the HIV rates. In 2012, they had 494 new cases. In 2015, they had 255 cases. I was scouring the web last night to see whether their 2016 numbers were. They haven't published them yet. But I'll bet you it's going to be lower. And so what we're seeing is that lowering of viral load by treating the people who have high viral loads and who are out there potentially spreading the illness, and then protecting those people who are not infected, we're seeing marked improvement. Now, there's some caveats. You've got to remember, this is San Francisco, all right? San Francisco has, I know what you're all thinking, but that's not what I was going to say yet. San Francisco has a very strong public health system, all right? They are geographically bounded. They're on a peninsula. You can walk across the city, okay? And they have a very active gay community. And when you put all those things together, it's working very well. Now contrast that to Houston, all right? So Houston is, I just heard today, Greater Houston's bigger than Massachusetts. We don't have a good public transportation system, and we don't have a strong public health system in Texas. And so you could see how it may or may not translate well. But despite that, you see things like the Harris County Hospital District doing testing in the ED for now 10 years and getting people referred very quickly. So there are workarounds and ways that we can do it if we're willing to try. We're going to make a lot of mistakes. We're not going to get everything right. But I think for the short term, short of a cure, short of a good vaccine, this is the way. And when people first proposed this, I was like, that'll never work. And then you see the data, and you go, wow, that's really amazing. So as we move forward, I think there are a couple of messages. One, we can prevent HIV. We can prevent HIV very effectively. And we can prevent HIV in a way that is not particularly intrusive and that is palatable and that individuals will take the medication, will want the medication. And we can prevent HIV by actually doing the right thing by the people that have it, i.e. identifying them quickly and getting them into care as quickly as we can. And so from that point of view, I'm very optimistic. So at that point, I will stop and take any questions, comments, or arguments. Thank you.